So, hi guys, welcome to Podcast Med. The topic of discussion in this podcast is endocrinology relating to the reproduction and pregnancy. We'll discuss the topic under these settings. Okay, firstly, we'll discuss about introduction or basics of endocrinology relating to reproduction, and then we'll discuss about hormone-wise functions and changes during the pregnancy. Then we'll go with changes in the each endocrine gland in the body. Coming to the basics, we here have corpus luteum and placenta. Okay, corpus luteum is the modified Graafian follicle, basically morphologically altered or modified Graafian follicle. Okay, this secretes four hormones. Okay, progesterone, 17 alpha hydroxy progesterone, estradiol, and androstenedione. These among these four, progesterone is the major one that it secretes, and corpus luteum, it almost secretes 40 mg of progesterone per day. And after implantation, what happens, this corpus luteum is maintained by human chorionic gonadotropin and human placental lactogen, which are secreted by syncytial tropoblast cells of placenta. Okay, HCG and HPL. Coming to the placenta, normally in pregnancy there is luteoplacental shift. What is this? This is the transfer of function of corpus luteum to placenta. Normally in normal female who is non-pregnant female, the corpus luteum have few functions, and those functions are shifted to placenta here. This is luteoplacental shift, and this placenta will act as temporary endocrine organ for some time. Then coming to the hormones of placenta, we have two types of hormones secreted. Okay, protein hormones and steroidal hormones. Under protein hormones, we have human chorionic gonadotropin, human placental lactogen, pregnancy specific beta 1 glycoprotein, pregnancy associated plasma protein A. These are protein hormones. And steroidal hormones are estrogen, progesterone, as usual. The principal site for this hormone synthesis in placenta is syncytial tropoblasts. Okay, coming to the beta HCG, that is human chorionic gonadotropin. This is one of the most diagnostic factor for pregnancy. Okay, it has two subunits, alpha subunit and beta subunit, where alpha subunit is similar to LH, FSH, and TSH from the normal human body, whereas beta subunit is normally unique to HCG itself. And the functions of HCG are it stimulates the secretion of progesterone by corpus luteum, and it also maintains corpus luteum. And HCG stimulates Leydig cells of male fetus. If the fetus is a male, it stimulates the Leydig cells and help in the release of testosterone. And it has also got immunosuppressive activity as well, which helps in opposing the immunorejection of fetus from the mother. Okay, then it also stimulates adrenal placental steroidogenesis. It also stimulates maternal thyroid, and that is thyrotropic activity, and it promotes secretion of relaxin from the corpus luteum as well. And then coming to levels of HCG at different phases of pregnancy. The HCG level starts to rise by 8 to 9 days post-fertilization. 8 to 9 days of post-fertilization itself. So it is the golden standard for diagnosis. And maximum levels of HCG can be 100 to 200 international units per ml. And it is seen between 60 and 70 days of pregnancy. Okay, HCG disappears from the circulation within 2 weeks following delivery. After delivery, it will disappear within 2 weeks. Coming to the human placental lactogen, that is about HCG. Now coming to HPL, it is also called human chorionic somatomyotropin. It is secreted. It is similar to the pituitary growth hormone and prolactin. Okay, so it does function as them, as it opposes the insulin action, and as normally we know that growth hormone antagonizes the insulin action, like that only HPL in this as it is similar to the growth hormone and prolactin. It also antagonizes the insulin action. It has growth promoting and lactogenic effects, and maternal insulin which is present will help in protein synthesis. What happens here is it antagonizes insulin action, so there will be increased glucose in the body. So the brain will think insulin is not enough, so because of that there is a lot of glucose in the body, and release more insulin. Okay, so this insulin helps in what? Protein synthesis. And HPL, it causes maternal lipolysis, and transfer of it also promotes the transfer of glucose and amino acids to the fetus. It is also potent angiogenic hormone. Okay, it will help in development of fetal vasculature, and it also promote growth and differentiation of breast for lactation, because it is also similar to prolactin from the normal human body. Okay, then coming to the pregnancy specific beta-1 glycoprotein, it is potent immunosuppressor and prevents rejection of conceptus, that is fetus. Okay, this is the only function of this, and it is detected in the maternal serum 18 to 20 days after ovulation. Okay, and we'll go with the pregnancy associated plasma protein here. Okay, it is a glycoprotein again, like HCG. It is secreted by villus trophoblast. It is not secreted here. This is secreted by villus trophoblast, not by syncytial trophoblast. Okay, and also it is one of the marker of triple tests that we do during the pregnancy for diagnosis of genetic anomalies. Low maternal serum levels of pregnancy associated plasma protein A is associated with increased risk of preeclampsia and IUGR. What is IUGR? Intrauterine growth retardation. Then till here we finished protein hormones. Okay, coming to the steroidal hormones, we have estrogen and progesterone, which is very similar to normal things. Okay, we'll have a few more things to discuss here. Estrogen is secreted here by syncytial trophoblast. Okay, and all of our other functions here are very similar to normal estrogen that it do. And coming to progesterone is synthesized and secreted in increasing amounts from the placenta. Okay, precursors from fetal origin are not necessary in estrogen production. Low progesterone levels are observed in ectopic pregnancy in abortion. Ectopic pregnancy and in abortion. High values are present in high-density formol. You understood? Progesterone levels, if they are increased, it may indicate there is presence of high-density formol, RH, and also RH isoimmunization. Okay, and the levels of progesterone, if they are low, it can indicate ectopic pregnancy and abortion. Okay, after delivery the placental progesterone decreases rapidly, and within 24 hours it will disappear. But HCG will take how many days? It will take 2 weeks after delivery to go out from the blood. And coming to the functions of steroid hormones, what are these? Estrogen, progesterone together do few functions. So estrogen causes hypertrophy and hyperplasia of uterine myometrium, and it increases the accommodation of capacity of blood flow. So hyperplasia and hypertrophy causes uterine myometrial hypertrophy and hyperplasia of uterine myometrium. There will be increased size of uterus by this, and it increases the accommodation, so that there will be increased accommodation capacity of the blood flow to uterus. Okay, then coming to the progesterone, it stimulates growth of the uterus, causes decidual changes. What is decidua? Decidua bacillaris, decidua capsularis. Okay, all of those three deciduas. The changes are brought about by progesterone, and which are required for implantation, and it also inhibits myometrial contraction. Okay, which will prevent abortions, or else the fetus or the growing fetus will be expelled out if there is myometrial contraction. Okay, coming to the development and hypertrophy of breast during the pregnancy is achieved by number of hormones. Okay, there are so many hormones involved in this. As we have discussed, a human placental lactogen helps in it, and these things also will help in it. Hypertrophy. Okay, these things also help in it. Okay, we'll discuss about breast hormone system now. Okay, the mammogenesis. The breast functions are divided into four. Okay, galactopoiesis, mammogenesis, lactogenesis, and galactokinesis. Galactokinesis is what? Ejection of milk. Okay, galactopoiesis is what? Formation of milk. Lactogenesis is formation of lactogen. Mammogenesis is duct system and lobulo-alveolar system formation in the breast. These are assisted by different hormones. Okay, coming to first mammogenesis. Mammogenesis may duct system is formed with the help of estrogen, adrenal steroids, and growth hormone. Lobulo-alveolar system is formed with the help of progesterone, estrogen, prolactin, adrenal steroids, and growth hormone. Duct system and lobulo-alveolar system is helped by estrogen, adrenal steroids, growth hormone combinedly. Okay. In addition, lobulo-alveolar system is also helped by progesterone, prolactin. In addition, okay, coming to the lactogenesis. This is helped by the hormones, what? Insulin, growth hormone. Paradoxically, both of them help in that. Insulin, growth hormone, glucocorticoids, thyroid hormones, prolactin. Okay, all of this help in lactogenesis. Coming to the galactopoiesis. Galactopoiesis is only helped by suckling. Suckling from the baby, and prolactin. Coming to galactokinesis. Galactokinesis is helped by the hormone oxytocin, which is secreted from what? Secreted from posterior pituitary. Then coming to the remaining steroidal hormones, we also got leptin and estriol here. Okay, leptin normally suppresses appetite through negative feedback effect, but in pregnancy there is central leptin resistance, so it allows a mother to be so much hungry and help in adipose tissue deposition and weight gain during the pregnancy. Okay, then coming to estriol. Estriol is important in case of fetal death, fetal anomalies, hydatidiform moles, placental sulfatase or aromatase deficiency, where the levels of estriol are low. Okay, it is first detected at 9 weeks. Okay, 0.05 nanogram per ml. It is very less. It will be there in very less amount, and it can increase gradually to 30 nanogram per ml. Okay, then after this we'll go with what is that? Gland wise explanation. Okay, coming to pituitary gland, we'll very quickly wrap it up. Coming to the pituitary gland, normally it is increased in weight. Every gland here is increased in weight. Okay, the glands involved here are pituitary gland, thyroid gland, adrenal cortex, parathyroid gland, pancreas. Okay, and it will increase. Pituitary will double its size actually. Almost 30 to 50% of its size it will increase. The thing we should remember here is sudden hypotension following postpartum hemorrhage may cause infarction of the gland, this pituitary gland, which is Sheehan syndrome. This is called Sheehan syndrome. Infarction of the pituitary gland because of the sudden hypotension during postpartum hemorrhage. The increase in the size is mainly because of hyperplasia of prolactin secreting cells, acidophilic prolactin secreting cells here. Okay, then serum prolactin levels obviously increases by 10 times, and there is transient temporary decrease in the TSH levels in the first trimester. It is due to thyrotropic effects of HCG. Okay, and then coming to the thyroid gland. Thyroid also, there is hyperplasia of thyroid gland occurring in normal pregnancy. Okay, maternal serum iodine levels fall due to increased renal loss, and also due to transplacental shift to the fetus. Okay, Then there is raise of basal metabolic rate, as usual that we have saw. Due to thyrotropic effect of HCG, there may be a transient temporary phase of hyperthyroidism. This is called a transient gestational thyrotoxicosis. Okay. Then the serum protein bound iodine is increased in pregnancy. Okay, iodine will increase in pregnancy. We have already discussed maternal serum iodine levels fall. Okay, but the serum protein bound iodine is increased. Okay. Coming to the adrenal cortex, there is significant increase in the serum levels of CRH, ACTH, aldosterone, deoxycorticosterone, and also corticosteroid binding globulin CBG, total cortisol, and free cortisol. Okay. Cortisol releasing CRH is cortisol releasing hormone, and ACTH is adrenocorticotropic hormone. Okay. Then there is hypercortisolism in pregnancy. It is because of increased plasma cortisol half-life and delayed plasma clearance by the kidneys. And there is also resetting of hypothalamic pituitary adrenal feedback mechanism, HPA axis ka resetting happens. This is the explanation for physiological cortisolism. Then coming to the parathyroid gland, there is maternal parathyroid hyperplasia, just like thyroid hyperplasia that has occurred, and there is normal. There is no changes in the PTH concentration in the pregnancy. PTH does not cross the placenta, but the calcium ions do cross against the concentration gradient. Okay. That is about parathyroid, not much of it. And coming to the pancreas, during pregnancy there is hypertrophy and hyperplasia of beta cells of islets of Langerhans and maternal pancreas. What is this? There is more hyperinsulinemia. It is because of what? HPL, human placental lactogen. It is similar to prolactin and growth hormone of human. Okay, so because of increased HPL levels, it opposes the action of insulin. So there will be increased glucose. Glucose increase stimulates the brain, and means what? There is increased glucose in the body. So the brain will think there is increased glucose in the body, insulin is not sufficient, will make pancreas or islets of pancreas secrete more insulin. So it will secrete more, and there is hyperinsulinemia because of that. Okay, that is the thing that happens in pancreas. Okay, that is it about hormonal changes in the pregnancy.